Now we're going to move on to a subject which has already been mentioned, namely Medicare Advantage and the possibilities of improving Medicare Advantage and perhaps turning it into what might be described, I hesitate to use this term, as premium support. First, a little bit of history. Only about 5 years ago, you will remember that there seemed to be a huge politically partisan divide over premium support. Republicans were for it. Democrats were for traditional Medicare. My friend, Congressman Paul Ryan, had precipitated this. He became my friend when we served together on Simpson Bowles, because he made a proposal for converting Medicare over time to premium support. It wasn't an original idea. As Henry said earlier, he and Bob Reischauer had floated this idea in the 1990s, and it had been featured in a bipartisan commission headed by Senator Breaux and Congressman Thomas, but not endorsed by that commission. The basic idea of premium support was that instead of guaranteeing to pay for a defined package of Medicare benefits, the government would guarantee a fixed contribution which beneficiaries could use to buy private insurance. The contribution would be risk-adjusted. It wouldn't be a single payment for everybody. It'd be risk-adjusted by age and health status. Obviously, it could be generous or not. And Paul Ryan's original proposal was not. It started, like most of these plans, by saying the average payment would be the average current payment under Medicare, but then it depends on how fast you grow it, and he grew that contribution only with prices, which would mean steep cuts in real benefits over a few years. He also phased out traditional Medicare. You'd only, if you were coming newly, if you were a new beneficiary of Medicare, you'd only have the premium support options. Well, there was a huge furor about that, and a wonderful video in which a Ryan-like figure pushed Granny over the cliff. You may remember, one of the most effective political ads I've ever seen. And Democrats rejected the whole idea of premium support, identifying it with the Ryan plan, and rejected including some much more moderate and sensible bipartisan plans, one of which I worked on with Paul Ginsburg and Pete Domenici, and another that Ryan himself worked on with Senator Ron Wyden. But it sort of dropped off the radar screen. The furor died down. But meanwhile, something interesting is happening. Choosing plans is becoming a more familiar part of American healthcare. The ACA has people choosing plans on exchanges. Isn't working perfectly yet, but it's becoming a familiar idea. Part D of Medicare has the whole Part D population choosing among plans. And then there's Medicare Advantage, which is a popular program, partly because, as Henry pointed out, it had been subsidized, but it has grown in enrollment even as the subsidies have been cut back, and it does involve Medicare beneficiaries choosing among private plans. So, and a possible idea is forget premium support, but why not start with Medicare Advantage, an idea that Paul Ginsberg actually suggested to me when we were working on the Domenici-Rivlin plan, but I said, no, can't do that. But here it seems maybe not such a bad idea. Now, my colleague Will Daniel and I wrote this paper to explore the advantages and the disadvantages, and we'll emphasize many of those, of introducing more competition among health plans into Medicare by reforming Medicare Advantage. And specifically in this paper, we analyzed two ideas. Plan one would change the way that Medicare Advantage plans are priced and would go for competitive bidding against each other. Plan two would broaden that competitive bidding to include fee-for-service medicine, which would be considered a plan coming in at the average cost in the area and competing with the private plans. Now, that's a form of premium support in which the government contribution would then be the competitively determined price of producing the Medicare benefit package in a particular area. So briefly, how does Medicare Advantage work now? The benchmark for bidding is the average fee-for-service cost in the area, and the area is normally a county. Private plans submit bids for delivering the Medicare package, and that is presumably the cost at which they could do that, but they're actually paid their bid plus a portion of the difference between that and the benchmark or the fee-for-service cost, and they can use that difference to cover extra benefits and or to lower cost sharing. Now, the paradox of the cost of Medicare Advantage is if you're against Medicare Advantage, you say that because of these subsidies and because of the way the bids work, the average payment to Medicare Advantage is higher than fee-for-service, and that's true. If you think Medicare Advantage isn't such a bad thing, then you point out that within areas, the bids for Medicare Advantage are lower, and the cost for Medicare Advantage is lower than fee-for-service. Now, how can both those things be true? It's true because the Medicare Advantage plans can underbid fee-for-service in the higher cost urban areas where health care is expensive. And those are where the highest proportion of Medicare and Advantage enrollees live. And also because under the current law, the Medicare Advantage plans are subsidized in low-cost areas. So suppose we change these rules a little bit. Our Plan 1, which you would set the Medicare Advantage price by competitive bidding among the plans themselves, would lower the cost of Medicare Advantage by all the evidence, especially in high-cost urban areas. But it would raise two big issues, which would also occur in Plan 2. One is simply whether to subsidize rural areas. We know that it would be necessary to do that, to have plans competing in the rural areas. Do we want to do that or not? You could say, let's forget those. That's where Medicare, traditional Medicare works, and we won't bother to subsidize private plans in the lower cost, mostly rural areas. The other big question is how well competition will actually work in the very concentrated markets, and they are concentrated, in which insurance plans operate. That's a big problem for the ACA. It would occur here, or does occur here as well. Our second plan would broaden that and say, let's include fee-for-service as just another plan. Let the fee-for-service average cost be an option, and let the Medicare Advantage plans bid against that. That would, by all the evidence, lower cost further, because there are certainly areas in which the lowest plan or the average of the plans would be lower than the fee-for-service cost. But it would raise two further problems. One is risk adjustment, which is an imperfect art. In general, Medicare Advantage enrollees are healthier, and they tend to shift to fee-for-service when they get sick, which is not surprising, because that's when you need a broader network and more choice. And the second question, which is sort of the basic philosophical point about Medicare, is what is it that we want to guarantee? Is it a particular package of benefits which can be delivered either under fee-for-service or under capitated plans? Or is it wanting to have you stick with a network that you're in or a doctor that you're with? If you allow our plan to kite competition, then in order to stay in your network or stay with your doctor, you might have to pay more. So our conclusion is a very cautious one. If we can solve those four problems, we could have a more efficient, lower cost system. But they're hard problems to solve. But but one thing to keep in mind is that, as we'll talk more about in the next session, traditional Medicare itself is evolving. It is possibly moving toward integrated, capitated plans and plans which accept risk. They may not be that different in the end from insurance companies. So we might end up, if we pursue these tracks, with choice among plans being normal, with integrated capitated systems being normal, but they'd be different kinds. Some of them would be run by providers, some of them would be run by insurance companies. Thank you, and now let me turn to our two able discussants, the first of whom would be Jim Capretta.
Oh, good morning. Thanks for the invitation to be a part of this. Thank you to Alice for inviting me to look at her paper and comment on it. I enjoyed the paper and very glad to be here as part of this long discussion today about Medicare and its future. I want to start by picking up a little bit on some of the things that were said in the previous panel and here by Alice. With respect to the fee-for-service program and why Medicare Advantage becomes an option, I think it's sort of easy for us to bemoan some of the shortcomings, I think, of Medicare Advantage, but I think Medicare Advantage really has emerged and is a large part of the program now, in large part because fee-for-service has its own sort of problems. And I think the way to understand that is to think of, if you have a fee-for-service program designed by any private insurance system, they would, by definition, have cost sharing associated with it. Because the way fee-for-service is supposed to work is that the provider decides that a service is needed, the beneficiary goes to that provider, has a problem, the provider decides that a service is necessary. The insurance component is essentially supposed to pay the claim, no questions asked, right? I mean, that's the way fee-for-service was thought of for very many years. And so if you don't have cost sharing associated with that, then the third-party payer, in this case the government, pays out claims on an unlimited basis. Anything that a provider decides is needed and the beneficiary is willing to take would be provided, and it would cost the third-party payer. So in the design of Medicare, of course, they imposed cost sharing. That's the only check on use in a fee-for-service system. The follow-on to that, though, in Medicare is that, of course, the very, very risk-averse population, or the elderly, immediately wanted more protection than the benefit provided in Medicare. And so very quickly, a Medigap market emerged, as did employer wraparound insurance. And so for the vast, vast majority of cases, going back decades now, the Medicare population, even though the statutory cost sharing has been quite high, the amount that has been paid at the point of service has been very, very low. The percentage of the population in Medicare fee-for-service that have been exposed to the statutory cost sharing is probably in the range of less than 10% of the fee-for-service population, because the vast majority have either our employer wraparound plan or they bought a Medigap coverage. Now, in the last several years, we've tried to move toward restricting how much that Medigap plan can cover with some modest changes, including the one that just got enacted. But the vast, vast majority of the situation is that fee-for-service is still essentially at the point of service a no-cost-sharing program for the vast, vast majority of participants. This explains Medicare fee-for-service. This is why Medicare fee-for-service for decades has been a high-volume, high-intensity program that, more than any other factor in the United States medicine, has contributed to fragmentation and the overbuilding of the medical delivery system. Lots of people bemoan that, but I'm just trying to explain that Medicare has been a big contributor to that. So it's because of that phenomenon. We have a very risk-averse population. We understand they would love to have zero cost-sharing health care, but you cannot have that with a passive third-party payer system. You have to have an active third-party payer system. And by definition, that was more developed on the private side than the public side. And so private insurance has stepped into that breach to some degree and become the mechanism for trying to manage more of the care. So that essentially explains, I think, why Medicare Advantage has grown. Now, a couple things to follow on, I think, relative to the paper from Alice. There's an interesting article that was published in the Milbank Quarterly 2 years ago, I believe, or so, by Newhouse and McGuire, that went through many of the same issues that Alice has raised as concerns about competition and the way to set up competition between the programs. And I just want to review a little bit about what they found. I think with respect to risk selection, there's been a lot of studies recently that try to show that as you move toward identifying higher paid diagnoses and adjusting for that within the payment system, Medicare has done that to a fair degree in the last decade, that the new research is saying, well, that may be true, but then you also find that they risk select within a payment or within a higher risk category. In other words, the insurers are adept at figuring out the high cost case that actually is a little bit lower cost, is the idea. You find someone who's going to get paid a high risk adjustment, and then you find that patient that, yes, they're going to get that high risk adjustment, but they're actually a little healthier than the normal for that big risk adjustment. And so they identify that kind of patient. Well, I think there's probably some truth to that. Insurers are pretty adept people. There's no doubt about it. But of course, the presumption in these studies has all been that the managed care plans, the HMOs, are not better at all in managing the care. They presume the entire differential for taking that higher risk patient is assigned to better health, not to any kind of management of care. Now, there may be, arguments about how well these HMOs are actually managing care in the private sector, but I very much disagree that it's zero. So that there's going to be some element of this which is associated with actual management of care. Another issue they raised in this comparison of how to get to better competition in the Medicare program was something they called, and I very much agree with, which is the non-transparent price competition that already exists between Medicare Advantage and fee-for-service. Right now what happens is if you sign up for, if you're on the Medicare program, your Part B premium is entirely withheld out of your Social Security check. So that's a big part of the price of the Medicare program. Medicare Advantage is allowed, if they want, to price compete with fee-for-service and offer a rebate against your Part B premium. The problem is that the rebate actually is then put back into your Social Security check. Now, that may be a good thing. Your Social Security check might go up $50 a month if you selected a very low-cost Medicare Advantage plan. But lots of economic evidence indicates that if someone makes a selection and then the reward for that is showing up in a third transaction that they barely pay attention to, they aren't really price sensitive at the point they make that decision. So what you probably need to do is have the Part B premium paid entirely by the beneficiary and then allow more direct price competition between the MA plans and the fee-for-service coverage. At that point, you will get, instead of huge bunching as you do now at zero premium plans, you might actually get some of the MA plans bidding even lower and driving down the cost below what they're doing today. I've run out of my time, so I don't want to abuse Bob's time. I have more things to say, but I'll save that for some of the discussion. Thank you very much.
Thank you. It's a pleasure to be here, and I will not take some of the bait that Jim threw at me, but and will stay with some of my prepared remarks. The first one will be to come out completely from left field, and it is to take some issue with the terminology of fee-for-service Medicare. And maybe this will demonstrate that I'm really an old curmudgeon, but it extends a caricature that just isn't true. Even the Medicare fee schedule for physicians, we now know that about a quarter of the activities that primary care physicians do aren't paid for. They don't get, fee-for-service is usually defined as the provider gets paid for every item and service they provide. But it's certainly not true for hospitals. Diagnosis-related groups is not fee-for-service. It is volume-related, and that is the issue. There's an incentive for generating more admissions, more readmissions. The reason I'm sort of quibbling about the terminology is that I think it leads to some sort of muddled thinking. So DRGs is for how we pay hospitals that's the old style. We're going to have payment reform. We're going to have bundled episodes in which we sort of pay a bundled amount for a doctor and a hospital together for providing an episode of a hospital care. That's one of the models. Somehow that is not volume-based. That's a payment reform. What we might get out of doing that is a very efficient focus factory to give patients high-quality, efficient care for something they don't need. And so the point I'm just making here is that as Alice said in her remarks, traditional Medicare is evolving, and that's what I want to spend the rest of my comments on, is to talk a little bit about the interactions between traditional Medicare and Medicare Advantage that set, let's say, challenges or that need to be kept in mind in thinking about any competitive structure, especially one in which traditional Medicare would be competing with Medicare Advantage. They've both talked about risk adjustment, and there's I've taken this opportunity to actually start catching up in the literature, and there is a very vibrant literature going on now about risk adjustment and its relationship to Medicare Advantage. And to briefly, my take on what's going on is that, yes, there still is favorable selection in plans that we're still not able to fully adjust for. The variations in different studies is pretty significant, from about 4% to mid-teens in terms of how much favorable selection there is. But Newhouse's group in particular are pretty reassuring that we're able to capture a lot of the risk differences. But what hasn't gotten much attention until very recently, and there's now one very important study by Cronick and Welch coming out of ASPE about the problem of coding intensity, which is that the beneficiaries in Medicare Advantage have whatever risks they have, but the health plans have figured out ways to code much higher levels of intensity for those people, so the payment is much higher. And that seems to be a growing issue, and there's just a study out by Garuso and Layton in the National Bureau of Health Economics, which is finally finding what some of us were quite concerned about, which is the association between coding intensity, meaning higher payments, and the degree of vertical integration, meaning the closer you get to the providers who actually check the boxes on the codes, the more likelihood you have that you're going to see higher than real codes. Or I won't necessarily make it pejorative, higher codes than the comparison, which is in traditional Medicare. And so one of my concerns about ACOs had been that they would be able to aggregate market power in their negotiations in the commercial sector when they negotiate with health plans, where if you sort of sanction vertically integrated systems. I think there will be an increasing challenge both within traditional Medicare, but also in any kind of level playing field discussion of competition about the ability to adjust for this demonstrated ability of coding intensity. Now, the Welch Kronig paper does demonstrate that CMS isn't helpless, but it's that they've made some changes and they can detect. In fact, what is going on is a coding intensity adjustment that applies across all plans. The problem is some plans are much more aggressive in this area than others, and so we have sort of rough justice going on. So risk adjustment remains a major challenge. The next topic I want to take up is one that doesn't get much attention at all, and it's work that I'm now involved with. They hope to publish in the very near future a study which sort of demonstrates the reasons why it is that Medicare Advantage plans pay hospitals basically at Medicare rates. I mean, the assumption had been by very smart people, and I'll put myself in this category, that private health plans paid commercial rates and therefore faced a major pricing disadvantage in comparison to traditional Medicare. Well, it turns out that there's this rule in the statute and then in regulations that says any patient who goes outside of their Medicare Advantage plan and sees a patient in traditional Medicare is paid at traditional Medicare rates. That completely changes negotiating dynamics. The hospital provider can either be in-network at Medicare rates or out-of-network at Medicare rates, essentially. Another factor we heard as to why this phenomenon happens is that there is real competition in Medicare Advantage with, guess what, traditional Medicare. If the hospital said we need 160% of Medicare, which is not atypical in the commercial sector, the MA plan is in a position to say we can't compete with traditional Medicare or with other MA plans at 160%. It's just become pretty well established that MA plans benefit from traditional Medicare. And in fact, CBO has provided some estimates that if traditional Medicare disappeared, there would be a migration up in the rates that private plans were paying to hospitals. We know very little about the pricing in all the other structures. I would say we need to understand that a lot more in thinking about how we would structure level playing field. I only have 1 or 2 minutes to go, so let me just tick off 3 or 4 other items that I think are in play when we think about level playing field competition. First would be 3-stop shopping versus 1-stop shopping. Right now in the system, if you want to stay in traditional Medicare, you've got one entity, traditional Medicare, for your medical services. You have a Medigap plan, and you have to go buy a Part D plan. It's a lot easier to do one-stop shopping, and so one of the real benefits, I think, to your guys, what is it, unified traditional Medicare Plus is to sort of even that sort of choice phenomenon. I never believed we would see a drop-off in enrollment in Medicare Advantage, partly because this advantage that was created, partly because the new generation of people moving into Medicare are much more used to dealing with networks and know how to navigate a little better. Marketing costs, I mean, clearly this goes in the other direction. Medicare Advantage plans, I think, have a legitimate point to make that Social Security Administration, the post office, everybody else is capturing some of traditional Medicare's marketing and enrollment costs. Medicare Advantage plans have to bear that, so that comparison is a little unfair. One of the real problems I would argue that traditional Medicare has is the lack of administrative support to manage its own program. There's an artificial limit on how much traditional Medicare has for administration. It's based on an appropriation. They can't tap the mandatory side trust fund to spend money to save money. So the GAO report last week that came out that basically bemoaned how CMS was doing with the Medicare physician fee schedule and traditional Medicare pointed to the fact that there were 10 people at Medicare, and therefore Medicare is overly dependent on the American Medical Association and all those docs out there for free labor. Medicare has no choice. So clearly we have a level playing field issue there. And the final thing I will mention, and I'm happy that you guys in your paper mentioned it, is this issue of new technology and coverage. Most people don't know that private plans, Medicare Advantage plans, actually have to follow Medicare coverage policy. They can't do what Mark Pauly has recommended. I'm not sure I agree with this, but he basically says a plan should be able to market last year's benefits at last year's prices. Be able to distinguish themselves based on what they are covering. It came up in the first panel this morning. A couple of different CMS administrators, Gail, I believe, was one of them, and Nancy Ann was another one, attempted to sort of bring some notion of value in the coverage process. Mark McClellan tried with coverage with evidence development. Most of that stuff is on the shelf at this point. Medicare doesn't have a very disciplined process, not just for doing cost effectiveness analysis, which, as you pointed out, isn't something that the program can do, but just effectiveness analysis. And private plans sort of have to live with that. I think it's an area that both traditional Medicare and MA plans would benefit with a relook at how that is all done. And I'm over time, so I'm stopping.
If we're not to shortchange the last panel, we have to move on to questions for which we have a short amount of time. Wait for the microphone and tell us who you are. Yes.
Hi, I'm Stu Gutterman with the Commonwealth Fund, and I've noticed that in a lot of discussions of premium support, or whatever people decide to call it, the concept of quality gets left out, and all the emphasis is on price. And I wonder if, for instance, if you decided to set the benchmark price at the average for all the 4- or 5-star plans in an area, whether that would change the picture. It would certainly emphasize the high-quality plans rather than just all the plans in the market.
Right. I think I was remiss in not mentioning quality. There has been a considerable effort to grade, as you noticed, to grade the Medicare Advantage plans and give them stars and give them bonuses for getting 5 stars, which has arguably helped offset the declining subsidy and may explain why there hasn't been as much exit as there might have been. But that's an interesting idea to set to emphasize quality even more in setting the competitive bid regulations.
I would just comment that there is a significant correlation between health plan quality scores on the star ratings and the underlying delivery systems, geographic delivery systems. Is in Massachusetts, you have a much better chance of having a high star plan than if you're in some parts of the South. So I think we'd have to be a little more careful about. So I guess the point I'm making is the plan in Tallahassee that is a 5-star plan is really doing something different than perhaps the plan in Massachusetts is doing. I think that needs to be taken into account in anything like this. I don't think we have the quality metrics that can be used for more than marginal refinements. The final point I would make is it's only upside only so far in the star ratings. Why not have the lower rated plans actually get less payment rather than it has helped with
penalize it, right.
It has helped deal with the reduction in the payments, but we are still in aggregate paying Medicare Advantage plans more than we are paying in traditional Medicare, and that could be budget neutral.
Yeah.
If we're convinced that those quality measures really are that important. I have mixed feelings about it.
But hope for the future. I hope that we get better at it.
Yeah, I always have hope for the future.
Yes.
I'm Dr. Caroline Poplin. How do you factor in a study from Wharton a couple of years ago that said that the money that was saved from Medicare Advantage was not going for additional benefits for patients? It was going for marketing and profits.
Well, part of it goes for marketing, and part of it goes for additional benefits. And the law has, the regulations have moved on that fairly recently. But you do raise the problem of private plans have to market, which Bob was saying earlier.
Yeah. I don't know that study in particular. I am aware. I mean, the bids that the plans submit are supposed to reflect their real costs with a limit on what's available for profit. If in fact that far exceeds that, then there's another administrative oversight problem. So I'd be happy to talk to you more about it.
I mean, there's 30% of the population is now in Medicare Advantage, so the beneficiary population it's a complicated choice, obviously, to join a Medicare Advantage plan. I agree with the previous panel. There's a lot of complexity in healthcare. But I doubt that the trend line would be continuing to go up if it was all just smoke and mirrors. They're probably the beneficiaries are choosing it for simplicity, a lower premium, lower cost sharing without Medigap coverage. If you look at the profile of the people that are in Medicare Advantage, they tend to be people who don't want to pay the $250 a month for a Medigap premium and can get a pretty comprehensive benefit package with simplicity and relatively straightforward management of their care through a Medicare Advantage plan. I don't think that's nothing.
Yeah, I would go on, and I mean, this was a point I was going to make, but ran short, which is I've been working for years trying to figure out what a level playing field competition would be between MA and traditional Medicare, but I'm changing my thinking a little bit, partly from the results of what we know about selection issues, that most people who join an MA plan are perfectly happy in an MA plan. The switching is in single digits, but the people who do switch back to traditional Medicare are sicker. And they're going for a particular reason, presumably, that being in traditional Medicare with more choice or specialized expertise, perhaps, of some providers who aren't in Medicare Advantage, offers them an opportunity for that time. While they're in Medicare Advantage, they're probably benefiting from the greater attention to chronic care management, some aspects of prevention that traditional Medicare has a hard time doing. So what's wrong with that, actually, that people would be in Medicare Advantage and are allowed to switch back into traditional Medicare rather than thinking about longer lock-in periods so that we have purer competition, to see them more as complementary. The point I was making about pricing is that if traditional Medicare sort of disappeared or became much smaller, we could have a significant increase in prices, or at least we'd have to establish regulatory prices. I actually think having those prices effectively be traditional Medicare prices is what is a reason Medicare Advantage is as affordable as it is, and that's a regulatory approach that in a way is supporting competition.
We've run out of time, so thank you very much, Jim and Bob, and we'll move on to the next panel.